I was asked to talk about, hey, how do you initiate buprenorphine in a supervised withdrawal management setting in a way that's responsive to what people are going through and helps to keep them engaged? Great. So this is geared more towards initiating in the inpatient setting and the role of your, your nurses and clinical staff in supporting that. Okay. So for some of it, it might be old news. And hopefully for some, it is right on point. Anyway, we'll just go and see what happens. Okay. Thank you, Kate, who wrote the title and the objectives for me. So that always helps. So first of all, I just want to start out like, why is this a bigger deal now than it was 5 or 6 years ago in terms of getting people onto buprenorphine? So really understanding the complexities of buprenorphine in this age of fentanyl, which we've been in for, well, more than 5 or 7 years. And what are some of the elements for a successful initiation in our supervised withdrawal management settings? And then what are some things we can do, again, to engage folks and be responsive to them during the process of buprenorphine initiation? So I kind of like this study, oh, for God's sake, from JAMA a couple of years ago. But just the real short story is that you can see from 2016 to 2022, buprenorphine initiations overall were going up, but during that same period, retention on buprenorphine was staying about the same. Really, only 20% of people who were being initiated were sticking with it, hence this kind of plateau here. So why is that? Well, the answer is fentanyl, and we'll discuss why it's particularly more difficult to get on and then stay on buprenorphine in the fentanyl era. So and one of the primary reasons of that is this phenomenon of precipitated withdrawal. And I'm going a little fast here just in the interest of time, but I'll try to, each slide explains, leading to the next one. So again, some of this might be review for some of you, but this idea of precipitated withdrawal is that buprenorphine, there's your opioid receptor that opioids, including buprenorphine, stick to. And buprenorphine has a very high affinity for that mu receptor. So if you've got other opioids sitting in that mu receptor, fentanyl or even morphine or heroin, when the buprenorphine comes along, it kicks off those other what we call full agonists, and the buprenorphine goes and sits in that receptor. So you have this really dramatic drop in mu receptor activation, and that's that experience of precipitated withdrawal. Over time, and we'll discuss why this is harder with fentanyl, that those receptors will fill back up again with buprenorphine, but that can take hours, days, and so people are really uncomfortable during that period. Okay. So what is it in particular about fentanyl that makes this risk of precipitated withdrawal worse and the overall initiation process longer and more uncomfortable? Well, it's kind of an interesting drug. It is, as we say, a full agonist. I tell patients it sits in that receptor and it goes to 11. The more that you add of fentanyl, the higher that activation of the mu receptor goes. And it's very lipophilic, so it gets into your brain. It's very fast acting. It gets into your brain quickly, but also it sequesters. It goes in it once you use fentanyl. It kind of sits in your fat tissue and stores there, and it can be mobilized. It will mobilize as you're trying to do that process of getting people off of the fentanyl and onto buprenorphine. The other thing that it does with repeated use, in addition to accumulating in adipose tissue, is that your kidneys, which clear fentanyl, they start to be less effective at clearing it over time. So you've got the more you use, the more it builds up in your system. And there's some anecdotal evidence, that's why this is in italics here, but that the more fentanyl you use, the less those mu receptors are sensitive to the fentanyl. So you start needing more and more. And even that mu receptor desensitization can be true for any opioid, including buprenorphine. So you're needing kind of more stuff and more powerful stuff in order to get that mu receptor to activate. And so all of these things together mean that it hangs around for a while, particularly this decreased renal clearance, how it accumulates in fat tissue. So for fentanyl itself, it can take, sort of the half-life can be up to 7 days. And for norfentanyl, its metabolite, it can be almost 2 weeks. So it's really hanging around. So basically, the analogy I give patients a lot is, and maybe I shouldn't use this, so tell me if this is in poor taste, but I'm like, it's like a cage fight, right? You've got fentanyl, which is hanging around and has a high affinity for the mu receptor, and that's going to be in a fight with buprenorphine. That's also, we're trying to get onto that mu receptor. And bupe's going to win, but we got to figure out how to sort of calm down that cage fight. Um, I won't take you through all this, but basically, back in the good old days when people would get on to buprenorphine with sort of typical or other opioids, we had a pretty predictable, typical withdrawal course. And with fentanyl, kind of all bets are off. Things can happen very unpredictably, and with a lot of variability. So when you stop using fentanyl, the withdrawal can start very quickly. That's why often people use, particularly with injection use, 2, 3, 12, 20 times a day. Those withdrawal symptoms can be much more intense. Um, Also, it not only comes on quicker, but sometimes because it hangs around for so long, you have to wait sometimes longer. Like with other opioids, you could wait 12 or 24 hours. Sometimes with fentanyl, you have to wait even longer to avoid that risk of precipitated withdrawal. And this is partly, I think, why this topic is so important of being responsive to symptoms. Those withdrawal symptoms, even once you get somebody on bupe, the withdrawal symptoms can come back. They can come, you think, oh, they're doing great. We've been on buprenorphine for, 12 hours, 24 hours, and then people start feeling lousy again. That's typical with fentanyl. And also, the withdrawal symptoms can be so different in different people. You hear a lot about muscle aches, low back pain, this real feeling of restlessness, but some people get terrible headaches. Some people have intractable nausea and vomiting. Okay, so I'll pause for a second, just because I've been kind of rifling through. Any initial questions kind of about what the problem is that we're trying to address, like why we lose people so much in terms of initiating and maintaining them on bupe. Okay, all right, good. So there are lots of different strategies for buprenorphine initiation, but for the purposes of today, particularly in a supervised withdrawal management setting, we're going to focus on just what we call high dose initiation, formerly called macro induction. You can call it whatever you want. I think the newest term is high dose initiation. Some of these other ones, particularly low dose initiation, are really that this is a really effective method, but we can't do that in the supervised withdrawal setting. So we really, I haven't used, I don't think any, I don't know, we haven't used standard initiation like we did for oxycodone in years. And these other ones are a little more advanced. Anyway, this is from another colleague, but this is kind of our standard one. So that's what we're going to focus on for the next 10, 15 minutes or so. And just to, I know everybody's seen this slide if you're into buprenorphine a million times, but just a reminder of kind of what we are doing here with initiation. You stop using your opioid, in this case, fentanyl. So that's kind of floating out there in the um, in the ether, I guess. And you've got this empty mu receptor, which is angry because it doesn't have any opioid in it. And back in the old standard buprenorphine days, we would tell people, you can wait 12, 24 hours until you're in sort of moderate opioid withdrawal. And then you administer the buprenorphine. It has an imperfect fit in the mu receptor, which means it's sort of turning the volume to 5, enough to make you feel well, but not enough to induce euphoria or respiratory depression. And in the old days, you would sort of you'd wait maybe 12, 24, 48 hours, gradually add the buprenorphine, probably start around 4 milligrams, and then titrate it up over several days to 12 or 16 milligrams. So high dose initiation works differently. And the reason that we do it is because we don't need to, if you can wait, I mean, we tend to wait a long time, often because patients are nervous about it, but you can get buprenorphine receptors at high doses onto these receptors more quickly. And that's kind of basically the big idea. I'll show you a picture here, which gives you a little better sense of what we're doing. So here's this, I really like this graph or this kind of representation of it. You've got, here is your risk on the y-axis is the risk of precipitated withdrawal. And on the x-axis is how much buprenorphine you're getting. So it's this idea of displacement, which means when you give buprenorphine, you are displacing fentanyl from the opioid receptor. Displacement versus agonism. And agonism is you're putting the buprenorphine on into the system and it is sitting on that mu receptor and agonizing it, okay? And you're going to have to displace the full opioid, but you want to then have as much agonism as possible. So if you give real low doses of buprenorphine, you'll have neither displacement, you won't have enough bup around to really displace that much fentanyl, and you won't have that much agonism either. You won't have enough buprenorphine to really sit on those receptors and saturate them. If you've got higher doses, you get displacement plus agonism, right? You're bumping the fentanyl off, but you have enough bup around to saturate those mu receptors. Between 2 and 8 milligrams there is what I call the precipitated withdrawal window, the PW window. In a fentanyl era, if you're giving people particularly 4 milligrams, you're sticking them right in the middle of this PW window, and you're causing a lot of displacement without a lot of agonism, and boy, do people not like that. And no harm, I mean, again, 10 years ago, we gave people 4 milligrams to start all the time. That was considered the standard dose. But right now, it's the number one thing you don't want to do. So this is just, I think, a nice pictorial representation of what that looks like. At less than 2 milligrams, this little red guy is fentanyl, and the blue guy is buprenorphine. At less than 2 milligrams, when you're giving somebody buprenorphine, again, you're getting neither displacement nor agonism. The bup's just kind of there, and the fentanyl's happily sitting there on its mu receptors. In between 2 and 8 milligrams, you are displacing a lot of fentanyl. You've got a lot of empty mu receptors, and you get a little bit of bup on those mu receptors, but not a lot of agonism, right? So mostly displacement, and that's why people are miserable. They have these screaming opioid receptors without anything in them. But then if you give a full 8 milligrams or more, and I'll show you that protocol in a second, again, you are getting that displacement. You're bumping fentanyl off of a lot of these mu receptors. But look how happy they are. You're getting plenty of agonism. There's plenty of bup around to sit in those opioid receptors and cool things out. Look, somebody's smiling. Look how happy we are. Okay, so that's the idea of high dose initiation. I'll tell you, people are scared because they think if you're giving them buprenorphine, they think they're going to end up in here, right? You're just going to bump off all that fentanyl, and there's not going to be enough buprenorphine around to help me. But you're going to say, we're going to give you high enough doses that it's going to saturate those receptors. Okay, so that's the nuts and bolts of it. Does that kind of, I'm going to scroll through here. Does that kind of make sense? Okay. So here's the protocol that we used when I was anyway, here's the protocol that I've used, and there are much more sophisticated ways of doing this where you start with low doses and we add a lot of Ativan, and I think for our purposes, just starting high dose initiation this is a pretty reasonable way to go. So when to start? Some people, like my colleagues in Oregon, say you can wait 36 hours. In the emergency departments, they're waiting like 8 or 12 hours. I think for our purposes here, waiting 48 hours is pretty conservative. Sometimes people can start sooner, but 36 to 48 hours from last use. Or if you don't want to use a time scale, you look at their COWS scale. I'll show you what that is in a second if you're not familiar. You want to have a pretty high COWS of greater than or equal to 16. And I think the most important thing
there.
Oh, Marilyn, I'm going to mute. Oh, let me see if I'm smart enough to do that. There you go. Um, uh, and you want to have at least 2 objective signs of withdrawal, like goosebumps you can feel, big pupils you can see their nose is running, you can see their eyes are tearing. There's no question about whether or not this person's in withdrawal. The other thing that we do, again, because that 48 hours can still be 36 hours can still be pretty uncomfortable since last use. I think if you're going to remember one thing from all of this, these adjunctive medications, which we used to call comfort meds, I don't call them that. They really are, they're not just comfort, they are part of the treatment of initiating buprenorphine. We start these the moment somebody comes in the door. And it's pretty high doses. And I'll show you, you can even crank it up further from here. But gabapentin, 600 milligrams 3 times a day for 3 days, just the minute they walk in the door. You can even extend it if you want past 3 days if somebody's really feeling benefit from it. But that's standard. And again, these aren't as needed. These are scheduled. The minute they hit the door, start clonidine, provided their blood pressure can tolerate it. And you can do that up to 20, continue it again because of that cage fight. You want to continue that adjunct for 24 hours after initiation with Zofran. And the reason we limit the Zofran and gabapentin is just because we don't want to you can have side effects from them, but you can continue it, longer if needed. But Zofran, 4 to 8 milligrams scheduled. And then using a muscle relaxer, we use a lot of methocarbamol, up to 1,500 milligrams 3 times a day. Continue that into 24 hours after initiation. Okay, so keep all those things are on board. Again, I've got other colleagues that are using low doses of Ativan through this period. Again, I think if you're just starting with high dose initiation, not adding benzos at the first outset is probably a safer thing, but we can certainly get to that. And then once you're ready to start, again, folks won't want to do this, but you kind of, I don't know, folks like Dawn Marie and Mary Ellen, I can see you guys there, or you can tell us how you talk folks into it. They might be nervous, like, I don't want to take that. You're going to put me into precipitated withdrawal. But really start with 8 milligrams, even 16 milligrams all at once. Again, you want to be on that right-hand side of the displacement and agonism curve. And then wait an hour. And if their COWS score is about the same, if there's sort of mild or no improvement in symptoms, you can give another 8 milligrams of bup and then reassess in another hour or 2. If they're doing not great, their COWS score has actually gotten much higher, worsened symptoms, you can give them 8, you could give them 16 milligrams. Again, you're really trying to push that buprenorphine agonism. And if they're like, that was great, I'm fine, my COWS score is down well below 10 or so, just reassess you can reassess in 2 hours, you could even wait a little bit longer. You can go up to pretty high doses on day 1, definitely up to 32 milligrams. I've seen some places give up to 40, but that doesn't mean that somebody needs to stay on that dose. Generally, you start the next day around 8 or 16 milligrams, go up to 24 on day 2, and that's usually sufficient. And then you're done. You're just maintaining after that. There's the COWS score if people are just, again, for you hadn't used this before, that's just looking at pretty, again, those objective signs are really your touchstone. So a few other things about adjunctive medications, again, using them before, during, after, even after the maintenance dose. And then for our nurses in the group, it's really nice to have a lot of these meds that are scheduled right up front. I had somebody say to me once, like when you're doing everything as needed, one, you're often chasing symptoms and not getting to those symptoms ahead of time, but also your nurses need to have 16 arms. You know, you've got all these people at all these different stages of withdrawal, and you're trying to do their assessments as opposed to just let's just get you comfortable. We've got a standard regimen that works. You can make some adjustments for liver disease or people over 65 or people who are pregnant. But by and large, the scheduled regimen remains pretty stable, and it's much easier for your techs and for your nurses. And then again, these are just additional medications, even at higher doses, that can be needed on top of scheduled meds. If you need to, you can use tizanidine as well. I like to be pretty judicious with promethazine for nausea. It can really add to sedation. Um, you can add hydroxyzine or even diphenhydramine. You can add more gabapentin. Sometimes people haven't slept in a long time or are really agitated, and a little, even just a whiff of olanzapine can be helpful. You don't need to do 5 milligrams 3 times a day. You can start at 2.5 twice a day. For very short courses, for those bad muscle aches, using pretty high dose ibuprofen. You're not going to keep them on this, but if for a day or two they need 3,200 milligrams of ibuprofen, it's not the end of the world. And if it keeps them there and comfortable, do it. Um, and then having some options on hand for sleep. Sometimes trazodone doesn't work. Um, Again, these are things to use judiciously. You just don't want to have lots of Seroquel and mirtazapine flying around. But again, kind of like the Zyprexa, to have those as a backup if somebody's not sleeping, can be other really helpful adjunctive medications. This is stuff we did this wonderful learning collaborative, particularly for pregnant people, about a year ago with New Horizons, I think, and with Milestone. And these were some things that they had recommended, which just sounded really great. And I think we used to a certain extent in different settings. So just maintaining a really comfortable environment. Does it smell good? There was, these were some folks from Oregon that were giving us some consultation, but put some essential oils in the shower. If you can give someone a massage, if you've got hot water bottles, easy foods to eat, hydration. Oh, sorry. I thought I took those two things out. That's odd. Anyway, just for if you're forget those last two bullets from a prior talk. And then really be on top of concern for precipitated withdrawal. There's this little, don't wait till it's bad. There's this kind of colloquialism called the telltale toe. And that one of the early signs, it can be lots of possible things, but a more common early sign of precipitated withdrawal is sort of dystonia and muscle spasticity in the leg. And you can start to see that in the toes. And that tells you, okay, I got to get on this precipitated withdrawal. And I'll tell you how to do that in a second. Two things, again, just to reiterate that you don't ever want to do. If somebody's like, I'm worried about starting at the 8 milligrams. Can I just take 4? Just the nurses and the people closer to the work in the room I don't know how you talk people out of that, but please do, because again, that just lands them right in the middle of that PW window. And also just using the cows to initiate. People can be very anxious and say, I'm really nauseous and I need to start Bupe, but they look fine. I had a guy like this just the other day at New Horizons. He's like, I need to start right away. And he had his legs crossed and he was sipping a cup of coffee and we were just chatting. And his cows was 16. And I was like, I don't think so, bud. I think we gotta wait a little longer. So just not using only the cows for initiation. So for precipitated withdrawal, you guys know this already. I'm just gonna skip that one and just tell you what the protocol is. So the first line is you give people more buprenorphine. Again, if you've got they're in that window there, you want to get them over that hump and into displacement with agonism. So you just start giving bupe. And again, this is the written protocol we have at New Horizons. But if we do it differently, speak up, folks. But you just start. You can give 8 milligrams. You could even give 16 milligrams. And then second line then is to initiate benzodiazepines again, and we do this very cautiously for risk of oversedation. If you have Ativan and you can do it IM, great. But if you can only give it orally, that's fine. If you don't have Ativan and you have diazepam, it's going to be slower onset, but you can use that as well. And then if those things aren't working, then you call the provider and hopefully, but usually adding more buprenorphine will do the trick. Okay, so that's all I have. Thanks everybody.